Good afternoon, and welcome to the Woodrow Wilson School's 2013 Gilbert Omenn Class of 61 Lecture in Science Policy. This lecture has been made possible through the generosity of Gilbert Omenn, a graduate of the great class of 1961, and currently director of the Center for Computational Medicine and Bioinformatics, and professor of internal medicine, human genetics, and public health at the University of Michigan, as well as with his wife, Martha Darling, really a distinguished MPA graduate from the even greater class of 1970, who has had a distinguished career in both the public and private sectors and most recently retired. And I'm guessing that that's not really a watch TV all day kind of retirement, from a consultancy with the National Academy of Sciences. I'm very pleased that we have with us this year's Omenn lecturer, Dr. Anthony Fauci, the world-renowned HIV/AIDS researcher and director of the National Institute of Allergy and Infectious Diseases. Dr. Fauci first came to the federal government when he came to the National Institutes of Health in 1968, and he's basically been working there ever since. As director of the National Institute of Allergy and Infectious Diseases, he oversees an extensive portfolio of basic and applied research to prevent, diagnose, and treat infectious diseases such as HIV/AIDS and other sexually transmitted infections, influenza, that's in the news these days, tuberculosis, and malaria. Dr. Fauci serves as one of the key advisors to the White House and Department of Health and Human Services on global AIDS issues and on initiatives to bolster medical and public health preparedness against emerging infectious disease threats. He was one of the principal architects of the President's Emergency Plan for AIDS Relief, which has already been responsible for saving millions of lives throughout the developing world. His talk today, Ending the HIV/AIDS Pandemic from Scientific Advances to Public Health Implementation, will focus on many of these issues, and I'm extremely pleased to present to you this year's Gilbert Omenn Class of 61 Lecture in Science Policy, Dr. Anthony Fauci.
Thank you very much, Dr. Rouse. It's a real pleasure to be here with you. To be here at Princeton, but also to give the Gil Omenn lecture, since Gil and I go back a very, very long time, decades, and actually in his contributions when he was in Washington and before then. So, as you can see from the title, I'm going to talk about ending the AIDS pandemic from two standpoints. One, from the science that got us to where one can implement, and then the both challenges and accomplishments in the public health implementation. Now, when you look at the numbers of HIV, one could actually ask, how does he have the audacity and maybe even presumption to talk about ending the HIV/AIDS pandemic? And that's where I want to bring with you over the next period of time that we have for this lecture. I want to start off by the map of the world. I happen to like maps. I've always liked maps. I like the deep blue of the ocean, the crisp green of the valleys, and the brown of the mountains. And when I used to look at maps, they were always a very, very pleasant feeling about looking at them. And this is the map, the way I saw it in my own mind, of the world before HIV/AIDS. And when you say the world before HIV/AIDS, it didn't really mean much until we now know that we're well into our 31st plus 10 months of the era of HIV/AIDS. And I reflect, I was just speaking to Cece a few minutes ago about my children. I have three daughters, 26, 23, and 20, and they have never known a world without AIDS, which is really strange when you think of that. Three children, one in graduate school and two in college, none of which has ever seen a world without AIDS. Now, getting back to this map, now when I see maps as an infectious disease and public health official, maps have patterns on them. And this is the map of the prevalence of HIV as of the last time it was counted at the end of 2012 by UNAIDS. And as in all infectious diseases, the dark densities are the high prevalences. So for those of you not familiar, 90+% of the infected people in the world are in the developing world, and 67% of them are in sub-Saharan Africa. So when I look at maps now, I get a little bit of a chill because the maps just keep reminding us not only of the enormity of the pandemic, but of the disparity of the pandemic, which brings us to a number of the policy issues. So, moving from there, these are the numbers that we're dealing with, and why I say I almost give you a caveat ahead of time about how I might be so presumptuous and audacious to say that I'm going to talk to you this afternoon about how we can actually come to the AIDS pandemic. There have been about 60 million people infected, 30 million dead, 34 million people living with HIV, 2.5 million new infections in 2011, the last time it was officially counted, and 1.7 million deaths in 2011 due to HIV/AIDS. In the United States, we're a bit complacent about this, but the numbers are very sobering. Over 600,000 deaths, 1.1 million people infected, about 20% of whom do not know that they are infected. And I'll get back to that in a moment because that's a very critical issue that has policy implications. And the other thing that is so much sobering is that there are 50,000 new infections each year, and it's been that way for 10 years, and there's an extraordinary health disparity within those 50,000, which I'll get back to shortly. So, let's fast forward now. In November of 2011, after much discussion with Secretary Clinton and her staff about where we were in the program, the Secretary gave us the honor of coming to the NIH and talking about the fact that we can, within a reasonable period of time, see an AIDS-free generation, which by definition, our definition, is no children born of AIDS, and the tipping point where the number of people going on therapy is greater than the number of people getting newly infected, and there's a sharp deflection in the incidence curve that will get us to an AIDS-free generation. So in the summer of this past year, July of 2012, the International AIDS Conference had the theme Turning the Tide Together Towards the End of AIDS. Now, I had the privilege and the honor of giving the opening keynote address at that, and what I'm going to do today is give you a very updated version of the fundamental points that I made, and really one of the reasons why Secretary Clinton came to the NIH to talk about her vision of an AIDS-free generation as opposed to someplace else. So when you talk about the end of AIDS, what are the steps towards that? The first and foremost, again, of that is the fundamental basic and clinical research that leads us to the interventions in the form of treatment and prevention, which in fact is the endpoint of the science. But there's another big gap that needs to be addressed, and that is the implementation of the interventions. And there's, an issue, I'm sure most of you appreciate that, but there's a big difference between efficacy and effectiveness. You can do a clinical trial and prove a drug works, it's efficacious. Whether it's effective in the real world is an entirely different thing. And that's kind of the bridge that you need to gap when you talk about the basic science that gets you to the interventions, and do they actually work in the real world? As a scientist, what I was emphasizing was the fundamental science to get you there. But that is not the only story. So let's talk a little bit about the basic and clinical research. By pure happenstance of being in the right place at the right time, if you want to say that, being someone that had been studying infectious diseases and immunology for a few years before HIV came in the summer of 1981, I had the opportunity of being involved in this field literally from a couple of weeks after the first report from the Centers for Disease and Control and Prevention. In June of 1981, 5 gay men from LA who presented with an unusual form of an infection that is only seen in immunosuppressed people. I thought it was a fluke. A month later, on July 4th of 1981, 26 additional patients curiously all gay, from LA, San Francisco, and New York, presenting not only with pneumocystis pneumonia, but with also Kaposi sarcoma. It was at that point that my professional and personal life was changed, because I decided, despite a rather successful career in infectious diseases and immunology, that I would turn my entire career around and study these patients. Now, the problem with that is that we had no idea what was going on, as you're going to see in a moment, because it was one of those unusual situations in medicine where everybody is dying, but you have no idea why. You can suspect it's a virus. You can suspect how it's being transmitted. Those were the early years. But with basic and clinical research, leading to all of the things you see on this slide, and I don't have the time to, nor will I go through each and every one of them, it was a series of incremental and then breakthrough steps. I'm sure you know that in science, nothing is linear. There's no such a thing as this in science. It's incremental, incremental, breakthrough, incremental, incremental, breakthrough. You don't get breakthroughs unless you get incremental increases. Very unusual that a breakthrough occurs in a vacuum. You really got to be lucky for that, because there's always somebody that did something before you. What we had in those first few years was nothing but taking care of desperately ill patients. Then came the first breakthrough, the identification of a virus by the French in 1983, and then the proof that it actually was the etiological agent by American investigators in 1984, which really then completely turned around how science was done in HIV/AIDS. And I'm going to go through with you, giving you some salient features so that we can then get to the point of what do you do with that knowledge. This is a picture of the genome of HIV with its structural and regulatory genes. On the left of the slide is a schematic diagram of what the virus might look like blown up on an electron microscope. This is unquestionably now the most studied virus in the history of virology. And I think that the result of that, I know the reason for that, is for the extraordinary resources that were put in, appropriately so, to address this issue. One of the most important things, and a real validation of the role of fundamental basic research and that translational road that you go through before you get an actual product. We talk about that a lot in medicine and science, and we wave our hands a lot about that. But this is an example of how it happened. The basic research looking at the replication cycle of HIV, from the initial binding, the entry, the reverse transcription, the integration of the reverse transcribed DNA into the nucleus, and then the transcription and the ultimate budding of a new virus. Scientists were working on that with no experience in clinical medicine, with no experience in developing drugs. But what they did was to allow for the identification of targets that are the fundamental basis for all of the drugs that we use now against HIV, from reverse transcriptase inhibitors to integrase inhibitors, fusion and entry inhibitors, and the important protease inhibitors. So that's a quick sketch of the fundamental science. Now, as I mentioned, it was the latter science that I mentioned that got us to what we call interventions. And interventions can be divided empirically, though there are a lot of other interventions, into the big ones, which is treatment and prevention. So let's take a look at treatment and where we have come over the last 30 years. So believe it or not, this is a picture of me in 1981 making rounds on patients at the NIH. I have to tell you that this period of time from 1981 to late 80s and into the early 90s were the darkest years of my medical career, and in many respects, the darkest years of my life, because it's very difficult to separate what you do during the day, because for the previous 10 years, I had been involved in developing relatively curative drugs for unusual diseases like inflammatory vasculitides and things like that. So I was on a high. This was great. Most of the time, patients would come to me. I'd give them a drug. They'd get better. I felt good. They felt good. Everything was good in the world. For several years, virtually every one of my patients died. In this picture, in this clinic, the room that I made rounds on actually this morning before I came here, that when someone came in with this disease, which we did not know what it was or what caused it, the median survival was 6 to 8 months, which means that 50% of your patients are dead in 6 to 8 months. You can't get much worse than that when you're dealing with prognostic issues. Then the science kicked in. And this is a schematic diagram. If you go from left to right on the slide, you see that the first drug, now remember, the first drug was AZT. Some of you may remember that drug. It was the first drug that was developed for HIV. The virus, as I mentioned in the previous slide, was discovered in '83 and proven to be '84 to be the etiologic agent. So I went from 1981 to 1987 without being able to treat a patient for their underlying disease. And all we had was treatment of opportunistic diseases, which is like putting a Band-Aid on a hemorrhage. And that went on until we then started the escalation. And over a period of years now, we have 30+ drugs, which when used in combination, have completely transformed the lives of HIV-infected individuals. The real transforming coming together was in 1996 when the triple combination of drugs became available. And the results were nothing short of breathtaking. So here is the slog through the years. I told you what happened from '81 to '87. In 1987 with AZT, this y-axis is the level of the virus, and this is time. We had the first diminution, modestly, of virus. Patients did well, but anyone who understands RNA viruses know that particularly ones that replicate rapidly, they are going to mutate when you have one drug. So this was short-lived optimism. Years later, when we had 2 drugs, we did much better, and it lasted longer. But people were still ultimately dying, and it was only until 1996 when the triple combination brought the virus down to below detectable level and kept it there, did we have a true transformation, such that now, as shown, and this is one of many cohorts from Johns Hopkins in Baltimore, in which investigators followed over 6,000 patients and showed what I can do now and what I do every day, not just me alone. There's anybody who's in a large medical center will do it. If a 20-year-old person comes into the clinic, that same room that I showed you before I had white hair, and said, I'm HIV infected, we find out, and I start them on drug and they stay on drug, you could mathematically model that they will live an additional 53 years. Which, if you just stop back and take a deep breath and think about that, that has to be one of the greatest advances from fundamental basic research up through a intervention that truly is life-saving. It's not only happening here in the developed world, but they're seeing the same thing, and I'll get back to PEPFAR and the Global Fund in a moment. In Uganda, in cohorts in which drugs are available, the same thing. People are actually having normal life expectancies, which would have been unheard of without even thinking about this when you think about drugs. That's the great news. You can celebrate that. Now we got some problems, and that is getting into some of the implementation. Some of you may have heard of the care continuum. Here is a problem. In the United States, there are 1.1 million people who are infected with HIV. Unfortunately, about 20% of them don't know that they are infected. I'm going to get back to what the situation with those 18 to 20% are. 66% of the total are linked to care. which means that 34% are not. Of those linked to care, 37% of the total are retained in care, 33% are prescribed drugs, and only 25% have suppressed their viral load. Why is that awful? It's awful because I'm going to show you in a few minutes that we know now that if you treat people and bring their viral load to below detectable level, it is extremely unlikely that they will infect someone else because their viral load is so low. We're going to get back to that in a moment. So how do you do that? What you've got to do to break that disparity in the clinical, in the continuum of care, is that we have a program that we're doing together with South Bronx. For those of you who've been to Washington, Northeast Washington and Anacostia is about what South Bronx is in New York. It's the same demography, the same morbidities, the same mortalities. We've got to figure out how we can access people, how you can test someone voluntarily, link them to care, get their virus suppressed, and keep them in care. And we'll get back to that in a moment because this is going to be critical. This is a big challenge. Now, in some countries, well, they're doing even better than we are because of the rather strong, and you could argue maybe a little bit too strong, leadership of President Paul Kagame. In Rwanda, there is a retention rate of 92% of people who get on therapy, and 98% of those have a viral load that's very low, which is the reason why Rwanda is doing so well. We're going to get back to the implication of this in a moment. Let's talk about prevention. Prevention in HIV can never be unidimensional, unlike some other infections. The only thing that can be unidimensional is abstinence, which doesn't work. So you have to have a combination. Now, in the early years, they were low tech, namely things like testing, counseling, use of condoms, harm reduction, etc. Then we developed biologically based, which I'll get into in a moment, and then I'm going to talk to you for a minute about this. So let's take a look at these. The use of condoms, something that's really very simple. We know it's efficacious. Is it effective? And in a study in Thailand where the Thai government mandated among military recruits and the public health officials that a 100% condom program was begun, and over a period of time, there was a 4-fold decrease in HIV and a 10-fold increase in other sexually transmitted diseases like syphilis and gonorrhea. What about testing and counseling? So let me just remind you of what I showed you a few moments ago, that about 20% of the people who are infected don't know they're infected. Why is that a critical group? In the United States, this is an astounding number, about 50% of the 50,000 infections occur from the 20% of people who don't know that they are infected. So if you could access them and treat them, you would cut down by 50% a number of infections that have stayed that way for 10 years. This is critical. Now, who are these people who are getting infected, many of whom don't know? They're very disproportionately African American. It is truly a disgrace, a shame, whatever you want to call it, in this country where 12% of the population is African American and 50+% of the new infections are among African Americans. And when you look at women, 60+% of the infections in women are among African Americans. And if you look at the sexual habits, they are no more risk takers than people who are not African American. So it isn't a conduct issue or the way you behave. It's being in a situation where you have such a high density of infection that the chances of coming into contact with someone that's infected is a self-propagating infectious disease truth. That's just the way it is. So besides being African American, they're mostly men who have sex with men in a society, particularly among African Americans, in which it is much less acceptable in the community to be a gay man. And many of them are not admitting they're gay men. They don't have the access to counseling. So you have 62% of the new infections are among men who have sex with men. And the other thing that's disturbing is that 26% of the estimated new infections were among essentially children, 13 to 24. So this, again, if you look at them, 57% of them are African Americans, 75% of them are men who have sex with men, and 60% of them don't know that they're infected. This is a big problem. Now, we're trying to address that. We're trying to make testing for HIV a universal part of health care. The CDC comes out with recommendations that everybody 15 to 64 should be tested with an opt-out. You don't start trying to get signatures before. You say, we're going to test you unless you tell me you don't want to be tested. That's good, and it's making an impact. The problem is many of the people who need it don't have access to health care, which is the reason why the Affordable Care Act, Obamacare, et cetera, is going to have a major impact on making this work by having care available to people. Now, we get to the biologically based situations. Prevention of mother-to-child transmission. This is truly one of the great breakthroughs. If you treat a mother for her HIV infection and bring her level of virus to below a detectable level, the chances are extraordinarily low that she will not infect her newborn infant during the perinatal period. So that in the United States, right now, there are 100 to 200 babies born with HIV infected. In the world, there's 1,000 to 2,000 a day born. So we are doing extremely well because we have prenatal care, and once you know the mother's infected, you treat the mother. Now, prevention of mother-to-child transmission in low and middle-income countries is doing very, very well. Coverage has reached about 57%, so we've saved about 400,000 babies over a 2-year period, but we still have a challenge that there are over 300,000 new pediatric infections in 2011, something we need to address. Male circumcision. Talking about a fluke in science, we had a study in the Rakai district of Rwanda, and we had what's called discordant couples. One is infected and the other is not. And we were following them even before we had treatment, and the investigators noticed that when the male was uninfected and the female was infected, the incidence of infection among uncircumcised males was much, much higher than the incidence of infection in circumcised males. So we did a study. We did a study in Kenya, Uganda, and South Africa. And we found out that if you medically supervise adult male circumcision, you decrease by about 70% or more the acquisition of infection. We can get into the biology of that during the question period, but this is a major breakthrough that needs to be implemented. If we had a vaccine that was 73% effective, you would see me on the White House lawn with President Obama announcing that. It is so effective, and yet we have not fully utilized this. Now, another important point, and this is critical, because this is the real world. What we're learning now is that there is a clear interaction, interdigitation, between biomedical interventions and behavior and adherence. And it gets to the difference between efficacy and effectiveness. And I'm going to give you some examples of that. Pre-exposure prophylaxis. We did a study among gay men who were practicing high-risk behavior. Take one pill of Truvada, which is 2 drugs together, every day and determine if that protects you. The study was 44% reduction in incidence. But when we went back, as I'm going to show you in a moment, and she asked, did you really take your medication? The results were strikingly different. I'll show you the data in a sec. The same with topical microbicides among women who were told prior to and immediately after sex, you put in a gel that's permeated with an antiretroviral. The study showed a 39% overall effectiveness. Marginal. However, when you questioned them and said, this is the whole study, but if you did blood tests and determine those who took it, those who actually took it, was over 90% effective. The women who actually used it was not 34, but 74% effective. So the interaction and the interrelationship between behavior and biology is huge. Another disturbing study that was published in March just of this year, that a microbicide study in South Africa and Zimbabwe of 5,000 women, the study was called off because it didn't work. And we found out that less than 30% of the women were actually using it. So we have a long way to go when you talk about behavioral modification and you're dealing with a biological intervention. Here's another breakthrough, treatment as prevention. I've been referring to it for a while. Treatment as prevention means you treat somebody to determine if, in fact, they can not only save their own life, but not infect someone else. This is very critical. When I was putting together the PEPFAR program with President Bush, there was a tension between the prevention versus the treatment. How much resources for prevention versus treatment. And there was a lot of discussion about that. There's no longer an argument about that now because treatment is prevention. And a study was that 1,700 serodiscordant couples, one infected, one not. You treat the infected person early or you wait. The bottom line is there was a 96% reduction in HIV transmission when the drug was given to people early rather than late, which means that if you could theoretically treat everybody who's HIV infected, the chances of their infecting anybody else is essentially, now I wouldn't say zero, it's not. You don't want to give that message. You still have to practice safe sex, but it's really very low. Okay, what about vaccine and a cure? Very, very quickly. Vaccine, I want to talk about scientific challenges before I end up with the implementation. If we could put a vaccine box in there, that would really be the nail in the coffin, I think, to HIV, because I'm going to show you how the modeling means we could likely do it even without a vaccine. We've been doing vaccines for 26 years. Only a few years ago, in an empiric study in Thailand, was there the first signal of efficacy, which was about 31%. It makes scientists very humble because we thought we needed cytolytic T cells and neutralizing antibodies, and we found out that the correlate of immunity, and these are just a bunch of papers from Nature and New England Journal of Medicine, that the protection was correlated with a non-neutralizing antibody against a component of the virus that is so variable that no one ever considers it when you want to design a vaccine. Talk about getting a kick in the butt thinking you're so smart in science. So now what's going on is that we are having vaccine direction based on an interesting phenomenon, and I hope we can talk about it during the questions, is that HIV is unlike any other virus that we've ever dealt with. Take smallpox, mumps, rubella, measles, polio. A person gets infected. There's morbidity and mortality, but the overwhelming majority of people recover, develop antibodies that completely clear the virus from the body, and you're protected for life against reinfection. So the smart vaccinologists for decades have been saying, let's mimic natural infection. The problem with HIV is that people very rarely, 20% of the time, make neutralizing antibodies, and they don't make it until 1 to 2 years after they're infected. So our natural immune response is terribly inadequate. So if you want to do vaccines, what you have to do is you have to do better than what nature does. You've got to take these epitopes and make them immunogens in a way that the body doesn't usually see it in infection. Because you want to make neutralizing antibodies against these parts of the virus, which you know are what's called neutralizing epitopes. This is going to be a tough challenge. And again, we could talk about that a little bit later. Cure, many of you have heard about cure. I can, again, talk about that during the questions. Be careful about cure. There are two types of cures. One is an eradication cure. And a cure, for example, you come into my office with, you have pneumococcal pneumonia, I give you penicillin, the pneumococcus is gone, it's cured. Cure means you can be well without treatment. An eradication cure is you're not only well without treatment, but the microbe that originally made you sick is gone. A functional cure means that the virus might be present, but it can be controlled long-term without therapy. And that's something that might be a more reasonable goal. So when you talk about cure, you have to purge the virus. Why is it so difficult to do that? Because HIV is a retrovirus. It integrates itself into the genome of the cell, and some of those cells are very, very long-lived. They constitute a reservoir for the virus so that every time you stop therapy, the virus comes back. That's a tough one. I'm not saying it's impossible, but it's tough. Functional cure can be starting very, very early before the virus initiates a reservoir. Some of you may have read about the Cure baby a couple of months ago that was presented at a meeting. That's exactly what happened. The baby was treated within hours after being born of an infected mother. The other is to enhance immunity, and another is to modify host cells to be resistant. These are difficult things. The more practical one would be likely start early and enhance the immune system. Now let's get to the implementation. This is really where the challenge lies now. As I mentioned to you, in 2002, President Bush sent me and Secretary Thompson to Africa to determine, could we put a program together that could actually treat people in the developing world where they could take medicine every single day. There was a lot of people who were very, very skeptical about that. I spent a considerable time there, modeled out a way that we can do that in a certain number of countries, and what was born, thanks to the cooperation from a lot of very good people in the White House and in the Congress, is that the President's Emergency Plan for AIDS Relief was actually born, which is now really one of the most important global health decisions that was ever made by the United States federal government. There's also the Global Fund, the philanthropies like the Bill and Melinda Gates Foundation, Médecins Sans Frontières, the Clinton Foundation, and host countries. So now I'm going to talk about this implementation. What is the impact of scaling up proven interventions? We know with the clinical trial, the science, that it's efficacious. Let's find out if it's effective in the field. So with PEPFAR and the Global Fund, when I went to Africa I've been there many times, but when I went to put together the PEPFAR program in 2002, there were less than 50,000 people in the low and middle income countries who are on therapy. Now about 8 million are on therapy, and if you look at the mathematical modeling, about 840,000 deaths were averted in 2011 alone. Mother-to-child transmission. If you put women on therapy, not only to prevent infection in their children, but to save their lives, if you look at the red circles, those are the number of pregnant women who've received therapy, and the blue bars are the percent of children who are infected during birth and after. A major accomplishment in the developing world. What about treatment of people? Do you really decrease the incidence? We did a very interesting study in KwaZulu-Natal in which we looked at a region in which there was 30% of the infected people were on therapy, and another region where only 10% were on therapy. If you look at the higher versus the lower, there was almost a 40% decrease in risk of acquiring infection. Hence, in the field, in the place where you want it to work, in KwaZulu-Natal, treatment is prevention. Circumcision. Non-Muslims don't get circumcised generally in Southern Africa or anywhere. If you look at the effect of circumcision, you could get people to be to be circumcised, and if you get it up from 0% circumcision to 35% circumcision, there was a 42% decrease in acquisition in non-Muslim men. So the Muslims get circumcised in that region. The ones who are getting much more infected with the non-Muslims, you circumcise them, and you decrease the HIV acquisition. Now, the good news is that it works. There's been over 800,000 circumcisions in 2011, up from 21,000 in 2008. However, we are still far short of our goal. And you got to figure out ways to get the goal. Now, this is a dark picture. This is me looking into a recovery room in Durban, South Africa, where I visited last fall, taking a look at some of our programs there. It's very interesting that traditionally the king of the Zulu nation told, this was Shaka Zulu back over 100 years ago, told the tribes people that to get circumcised would make you a weak warrior, so they didn't get circumcised. So now, all of the uncircumcised, not all, but a high disparity of circumcised people are getting infected. So the current king of the Zulu nation is saying, I want everybody to get circumcised. And I visited this clinic, and they were circumcising 50 Zulus a day. Now, that's a very unusual way of implementation, because the king says, go get circumcised. Good for the king. Okay, so now with all of that, let's take a look at what's happened. We've had about 22% decrease since 2001 in new infections and about a 25% decrease in death. So we are on the way of that deflection. The trouble is we need to accelerate it. So you do modeling about the impact of scaling up, and you could pick whatever one you want. Antiretroviral therapy, microbicides, mother-to-child transmission, male circumcision, or even a vaccine. I put question mark in a vaccine because we don't have a vaccine, so it's kind of tough, but you could still model if you had a 40, 50, or 60%. So when you look at the models, the status quo before we started to really push meant that things were going down, but they were going to take a really long time. Don't ever make predictions in time, so I put 2000 question mark, question mark. So I don't have any idea when that would have happened. But what the model tells us, based on the good data that we have, that if you accelerate modestly, you're going to dip that curve down. Because infectious diseases have a way of, when they're going the wrong direction, self-propagating themselves. But when they go in the right direction, they reverse propagate and essentially make it more difficult to get infected. If you do it even more, the curve comes down, and then hopefully if you have a vaccine, this is what can happen, and this is what we're hoping for. So let's get right down to the present. PEPFAR and the Global Fund is working. Hillary Clinton, before she decided to leave and leave, asked Eric Goosby, who's the current ambassador, and myself and a few others, to put together what she called a blueprint for PEPFAR, to figure out how we can make it implement and work very, very well. And true to her form, she said science has to be a very important part of that. But the way this is going to work is that there will have to be, and there is now, we're seeing it in Rwanda, we're seeing it in South Africa, we're seeing it in other places, that the country has to assume ownership of the problem. We can't be a donor country. We have to be a partner until those countries can do it themselves. They got to strengthen health systems, increase commitment of traditional partners, involve new partners. Where are the BRIC countries in this? Where is the private sector? Partner coordination. Importantly, for a government thing, focus on what works and stop what doesn't work. And then remove the barriers, such as many legal, political, and stigma barriers that we still have. If, in fact, we do this, I actually feel confident. I'm a very cautious optimist. I'm an optimist, but a very cautious one. But I think if we implement this and go through the same steps with the big base being the research that gets us to where we're going, that what we're going to see is that this dreaded map that gives me goose pimples every time I look at it, over the years, and I hope not many years, is going to start doing this, and this, and this, and this, and then someday I would return to Princeton and talk to you about the fact that we have now reached an AIDS-free generation. Thank you. Yeah, I'd love to. Yeah, sure.
So Dr. Fauci is open to answer questions. We have 2 microphones here. We always encourage students to come down and ask questions first.
Hi, Dr. Fauci. Thank you so much for your presentation. I'm an undergrad at Princeton, and earlier this semester, I actually did a project that examined the male circumcision trials that were studied in Africa. And I also feel very optimistic about this intervention effort, but I'm concerned about 2 barriers that might let it go astray or even result in a worse situation. And that is that the message comes across that male circumcision is an effective intervention effort, and that clinics will open up all across Africa where communities and local people are doing these circumcisions and not using hygienic practices, or effectively telling patients that even after the circumcision they have to wait a certain amount of time for it to heal in order for that intervention effort to be effective. And I'm wondering whether how we can address these challenges, and whether it's important for organizations like the WHO or other organizations to even be pushing for circumcision to the extent that they are now.
Yeah, well, that's a very good question. One of the issues that you brought up is an important one, is that immediately following circumcision, before the wound is healed, if you do have risky sexual behavior and get exposed to the virus, you have an even greater chance of getting infected, because you have essentially an open healing wound there with a lot of inflammation. The fact is that it has worked, because, the programs that they're doing, as an example in Durban, is very, very well integrated with the counseling of what you need to do. The discouragement of doing this on the fly is something that we now have. First only the doctors did it, and then you have nurse practitioners, and people are starting who have skills to be able to do it. To get somebody who doesn't practice sterile technique, who is not qualified, is obviously something that everybody's attuned to making sure it doesn't happen. So your caveats are valid, but if you look at the 800,000+ circumcisions that have occurred, they've occurred fundamentally in a medically supervised way, even though you will always have people who are going to try and do it on the side for profit as opposed to doing it for a public health reason. But you can't let the perfect be the enemy of the good. You want to make sure you don't slow down the circumcision because of that.
Thank you.
You're welcome.
Hello, thank you very much for your talk today. I was just curious about your thoughts on the development of a vaccine, and specifically, you discussed earlier whether you think that it's possible to really end the epidemic effectively without a vaccine, given the threat of resistance and drug toxicity and adherence. And just on a second point, your thoughts on the NIH's funding of vaccine research, whether it should be done in the collaboration grants way it's done now through CHAVID, or whether it should be done by getting more young investigators involved?
Okay, that's 3.5 separate questions. I'll try to remember them. They're good questions. So don't anyone walk out of this room and say that I said that we can end the pandemic without a vaccine, because all of my vaccine colleagues are going to send me 1,000 emails and I'll never be able to do my work. A vaccine is a very, very important component, but we're seeing a trajectory down even without a vaccine, which tells us not anything pejorative about a vaccine, but that if you implement the public health treatment and prevention measures, you can make great headway. So a vaccine is highly desirable. It's also very difficult for some of the reasons that I told you. So that was one question. The second is, you're asking inside baseball question that maybe people are not going to understand. We have, but I'm going to explain it to you. We have been struggling with trying to get enough really good information about how you can develop a vaccine, because it's so unprecedented that the body's immune response is completely inadequate. It gives you hints that it can do it. A small number of people make neutralizing antibodies. It takes them a year or two. Why is that? There's molecular reasons. You have to have a hypermutated, high-affinity antibody, and it doesn't happen right away. The question the gentleman was asking is that we put together a consortium of investigators called CHAVI, the Centers for HIV Vaccine Immunology-I Immunogen, which I'm sure you're committed to. There's a perception, with all due respect, incorrect, that money put into consortia takes away money from young investigators. If you go into the CHAVI, both of them, the one that's in the combination of La Jolla and Boston and the one down at Duke, there are a lot of young investigators there. And we make a very important point to protect as best as we can in the investigator-initiated research pool. And that's our first and foremost. But the advances that have come through the CHAVI program have been breathtaking. I mean, they really have. And I'm sure, since you asked the question, you must know what they are. They really are important. Okay, and you say, what do I think about the budget? So we've been flat for 10 years, and now we have a 5% sequestration. What do I think about the budget? Okay.
Thank you, Dr. Fauci, for your talk. I am more curious also just about how you go about the treatment and prevention with regards to culture. As your example said with the Zulu prince 100 years ago, it was be a man, and now it's be a man and cut it off. So and the thing is, in many of these cultures, it's really, it's still a very taboo subject.
Right.
And while, you know, treatments in biology and science is great, if people universally don't understand or aren't educated or don't, you know, have a cultural misunderstanding or miscomprehension of it, how do you see the long term? Like, how do you see changing cultural and...
Well, that's, well, okay, I'm going to try and give you a short answer to that, but hopefully an accurate, not accurate, but at least a cogent answer for that. There are a number of barriers. This one is really important because there are still legal, political, and stigma barriers in some of those countries that require a combination of getting community people involved in convincing people of the importance, but importantly, removing the stigma associated with being HIV infected. It is not going to be an easy problem. Women in many places in Southern Africa and other developing countries are disgracefully disenfranchised. The way that stops is when you get leadership from above. Some countries are doing a good job of that. Kagame is doing a very good job. South Africa is doing a good job now, but years ago it was a total disaster with, I can say right now, because I don't think I can get sued, with a completely crazy minister of health. I mean, that was, and a president who, quite frankly, made the mistake of a president shouldn't get in front of a computer and start surfing the net because you should let your staff do that. And there was a real problem. So you need leadership and you need cultural changes. But they have to come from within, which is the reason why, as Secretary Clinton keeps emphasizing about country ownership, where they realize that they have a problem that they've got to fix. It can, you know, I say this somewhat tongue-in-cheek, the program in Washington and South Bronx, you have to train the people that you don't need a white guy in a suit going to Anacostia telling you how to behave. You need somebody that the community knows and relates to. And I think it's the same thing in those countries. Changing cultural barriers is, I'd be obviously fooling you, but I know I can't fool you, to say that that's going to be easy. It's going to be very difficult, but you just got to keep working at it.
Thank you very much.
Right.
How do you define efficacy? Second, why circumcision? Why is that so effective? And thirdly, how have you gotten control of a virus?
How have
you gotten control over the virus?
Okay, I'm not sure what you mean by control, but I'll try to answer that.
You've obviously mitigated the effect.
Okay, all right. So let's start with the first one. Efficacy is under the best circumstances. You do a clinical trial. You have X number of people. You see them in clinic 5 times a month, you know, once every 2 weeks. You have a special nurse practitioner who deals with them, counsels them, et cetera. It's the optimum condition. So when you give the drug, you do the circumcision, you do this, you know that under optimum situations, it works. It's an efficacious drug. Effective means, does it really have an impact when you're out there in the real world using it? And the Best example of that is that if a person takes their pre-exposure prophylaxis every day, it's 95, I put 92, but it's up to 99% efficacious. If you go out into the community and you forget to take it, or you think, well, I'm not so sure this person is infected, or I'm a little bit drunk, or I'm a little bit this and that, and you don't take it, it's not an effective therapy. It's efficacious, but it's not effective. That's the first thing. The other thing, circumcision works is because in an uncircumcised anatomical situation, the foreskin that's over the glands of the penis has a degree of flora of bacteria that make the mucosa not infected necessarily, but more like a thin rectal or vaginal mucosa that's mucosa as opposed to keratinized skin. So keratinized skin, it's tough to get the virus through that. So you're dealing with the difference simply between a mucosal surface, which is thin, friable, and easily gets virus to go through it, and a skin, which is very difficult to do. So after a period of time following circumcision, part that looked like mucosa actually becomes almost like skin. And that's a protective mechanism. So that's how that works. And with regard to, the virus is highly sensitive to an antiretroviral drug. So if the virus comes in and starts replicating and destroying your body's immune system, when you stop the replication of the virus, that's it. It doesn't destroy anything anymore.
Why hasn't it worked?
Why hasn't it worked?
No, why hasn't it morphed, responded to your treatments?
Why hasn't it more?
Viruses respond.
Well, HIV happens to be a very responsive virus to a combination of drugs. We don't have a drug for every virus. We don't have a drug for rabies. We don't have a drug for some of the others. We have a drug for HIV. The difficulty is you have to take it every day. It doesn't go away after a week. Yeah.
Hi, Dr. Fauci. Thank you so much for your talk today. I guess the cornerstone of prevention, at least, is safe sex in regards to HIV transmission. I work at a HIV center in Philadelphia, and a lot of serodiscordant couples there, specifically male positive, female negative, have expressed the wish to have children, to conceive. Do you think that with kind of the data surrounding PrEP and, I guess, maternal HIV transmission potentially being stopped, is there a case to be made for natural conception?
The success in people who are discordant has been spectacular. There's so many different ways to do that. You can, first of all, when you put the person on therapy, you get their viral load down to below, most of the time, you can get them down to below detectable level. That still doesn't mean that there is not some infected cells in the sperm and the other cells that go along with the sperm. You can wash the sperm down and just do pure sperm. Sperm does not get infected. The lymphocytes and monocytes in the ejaculate can have that. So you could actually spin the sperm down, artificially inseminate, or even do an in vitro to make sure you examine each and every one. So it can be done.
But I mean, I think so this clinic in particular serves low-income individuals, and I guess sperm washing and IVF and similar techniques aren't really that accessible to a large chunk of people, and especially, I guess, this can be extrapolated to overseas work too, where childbearing is sort of a must in some cultures, and fertility clinics may not be so available. So without those kind of technologies, I guess, is there a case, maybe not natural conception exactly, but sort of guided, antiretroviral treatments and just unprotected sex, just in terms of condoms?
Yeah, okay. So again, I'm going to give you an answer that's a practical answer, but don't turn it into policy for me, okay? So if you get the person and treat them to below detectable level, the likelihood of transmitting infection to the mother, the likelihood is vanishingly small. So you do a risk assessment, risk-benefit discussion with the person. And even without sperm washing, even without anything else, the chances are vanishingly low. Do they want to take that chance or not? Many people would. If they said there's a less than 1% chance of being infected, many of them would. Because if you look at the discordant couple studies, when you get virus below a certain level, it's very, very difficult to transmit. Very difficult.
Thank you so much.
Right.
Hi, thank you so much for your talk. My name is Ruthie Berger. I'm a PhD student here, and I'm studying HIV. I had a question about the slide that you showed with the diminishing proportions of people achieving each step in the continuum of care. And if that's the case for trying to get people who are already sick on treatment, do you have any concerns or basically recommendations for when something like PrEP is starting to be rolled out, or if there is a vaccine eventually trying to maximize adherence to PrEP or maximize access to vaccine coverage?
First of all, let me correct what is a very understandable misperception. Those people aren't necessarily sick. The best incentive for somebody to take their therapy is when you're sick. It's when you feel good and somebody says you're HIV infected.
Yeah, sorry, I meant infected.
Yeah,
but yeah.
you know, so that's the real problem. So the real problem is education to get people to appreciate that they will get sick. And that's the reason why education and counseling are so important in all of this. I don't believe that if we get a vaccine that we're going to have trouble getting high-risk people vaccinated. I think that, see, there's two types of epidemic. There's a generalized epidemic where the whole population is, you know, early when Botswana was 20-some-odd%. South Africa is about 10 or 11%. And then there's a specific to population. There's not a generalized epidemic in the United States. So in the United States, the epidemic is highly concentrated among certain groups. And if you look at the numbers that I showed you, that's predominantly men who have sex with men, African Americans as opposed to white. That doesn't mean that there are not other people out there who get infected. They're rare, but they're not part of the core group. So what you really have got to do is you got to direct those interventions mostly at the people who are in those groups. And that's where you need to educate them about what their risk is. I'm telling you things and I'm saying them, please don't think I think they're easy. Because, and I'll just give you a sociological example because I've done this. You know, early on in the epidemic when I would go to the Castro district or go to in Bed-Stuy or Crown Heights or other places or, you know, any other place that you go, people are more worried about getting shot. They're more worried about other things than HIV. I mean, what are you talking to me about HIV for? I got enough problems. You know, my brother got killed, my father's in jail, and you're talking to me about HIV. We got to get beyond that. And the only way to get beyond that is to try to get the people who they respect and listen to get them to understand that.
Thank you. Can I ask a brief follow-up question?
Sure.
So with, in particular with PrEP, less so with vaccines, there is a high risk of an individual developing a resistant form of the virus if they're on PrEP and then they're not adherent and they get infected. And do you think that that risk is worth it starting to roll out PrEP, or do you think it's necessary to get something that's more efficacious or try to establish better adherence regimens in a lot of these high-risk communities before it's actually rolled out?
Okay, so there's always the threat. You will never induce a resistant organism if you don't get infected. So a lot of people misunderstand it. They say, well, you take PrEP and you're going to get resistant. The only time you can induce a resistance if you get infected because you didn't take PrEP 3 nights ago, and then you go on PrEP, which is 2 drugs instead of the 3 drugs, and you select for a resistant organism. That's entirely conceivable that that could happen. The way around that is to better develop adherence, and we're working on now long-acting drugs that you might be able to take 1 every couple of months or so. That's the good news. The bad news is that if you have a drug toxicity, you got to figure out a way to turn the drug off. So there's a lot of challenges with that. But long-acting antiretrovirals is a major thrust that we're pursuing to avoid this problem of adherence.
Thanks so much.
Hi,
Hi, I had a question about one of your little boxes up there that you didn't talk about. Can you discuss the role of sexually transmitted infections and the role that's going to play in policy in terms of bringing this into discussion for screening and treatment in order to reduce HIV transmission?
Okay, so what is the cofactor component of another sexually transmitted disease? Okay, so that's a very good question. I didn't have time to go into it. But if you have an erosive or genital ulcerative disease, you dramatically increase the likelihood that you will be infected with HIV if you get exposed to HIV, for the same reason of the anatomical considerations of my explanation about circumcision. Of course, it's a raw surface. So the treatment of other sexually transmitted diseases can have a major role in diminishing the likelihood. So that gets to the point of where we are going now with HIV, that we're trying, at least in the developing world, hopefully with the advances in healthcare availability in this country, we could do it even here. But if you go to the developing world, is to use the PEPFAR and the Global Fund model to not only be for HIV, but to be a one-stop shopping, vaccination for your child of measles, HPV determination for the mother so that she doesn't develop cervical cancer, nutritional advice and supplementation, all those kinds of things. One of them is to examine for and treat sexually transmitted diseases.
Thank you.
Right.
Hi, I have two quick questions. The first is, in the natural course of any epidemic, you know, it starts off higher like this, and then it's going to start to go down anyway. And so I'm wondering, how do we know that the reductions that we're seeing in HIV in terms of incidence and prevalence are statistically different from what we would have seen in the absence of some sort of intervention? And then the second question is about concurrency. Your talk didn't really touch on the issue of when people have multiple concurrent partners at the same time, HIV is much more likely to spread in that community rather than when people are serially monogamous.
Right.
And there's been a lot of evidence that that was a big part of what was effective in Uganda. So I'm curious if you could comment a bit about that
Okay,
role.
those are good questions. I had a limit. I tried to stay to my time, so I couldn't give you everything. The data, if you look at the curves, that's everybody in the world going down. If you look at places where you study and show when you go in and do interventions, it drops in a way that is completely incompatible with natural attrition of epidemics. Completely incompatible. So there's no doubt that there is a saturational effect if you have a static population, but if you look at the new people coming into the risk pool, the 50,000 new infections each year in the United States negates what you're saying, that it's just naturally going down. Okay? It's our lack of ability to access them that they're doing that. When you've studied those who you access, the curves are totally incompatible with a saturational effect. And now you asked the other question, I'm sorry, what?
Concurrency
Oh,
versus...
yeah. That's a very, very good question. There's a phenomenon, which I'm sure you're familiar with, which is multiple concurrent sexual partners. And when you have multiple concurrent sexual partners, if one of them gets infected and there is sexual exposure among the others, the likelihood, particularly during acute infection when the viral load really goes sky high in the millions, of infecting others is a multiplying factor that is amazing. Now, then there's serial monogamy. So somebody could have 30 sexual partners in their life. One for a year, 6 months, 5 years, get married, get divorced, and on and on. And then you look at the lifetime and say, my God, you've had 30, 35 sexual partners. That's a big difference than having 5 or 6 sexual partners, all of whom are sleeping with each other. I mean, the risk of that is infinitely greater than serial monogamy with many sexual partners. And it's just for the reason that when one person gets infected, there's a critical time where there's more likelihood of transmitting it.
I guess my question was on sort of interventions, though, to address that, like in Uganda, where they encouraged people to have fewer concurrent partners,
Right.
and that was really successful on a population level in bringing down
Right.
HIV.
Right, yeah, and that is what we're trying to do in all countries. You know, the real sad, totally tragic situation that occurred in the United States, which I'm sure those of you who've read about that realize how difficult that was, is that the great thing about the late 60s was the Stonewall riots in New York City's Greenwich Village, when the gay population said enough of this, you know, harassing on us. That was followed by an explosion of expression of sexual identity and the bathhouse culture. So if there is ever a place where there's multiple concomitant sexual partners, is in a bathhouse culture. And unfortunately for the population, that's exactly when the virus was introduced. So that was just a terrible tragedy of timing of that. And that was the real example of what multiple concurrent partners mean.
So we have time for 2 more questions, and I'm going to go ahead and take them. Okay, I'll take 3 questions, but all at the same time.
Hi, Dr. Fauci. Thank
Hi.
you for coming today. So say alternative methods aren't effective. We talked about efficacy versus effectiveness. I think there's been evidence that with male circumcision, while it could be efficacious, people might be circumcised and then go out and think they're invincible and practice more risky behavior. So say that's not as effective as we wanted. Vaccine development is still far off. Worst case scenario, and we're relying on ARVs. I think the number is that with every 2 people who are put on ARVs, there are 5 new infections. That looks like that's not the best trajectory. Do you have kind of a long-term view, where we'll be in 20, 30 years?
Yeah, see, that trajectory is going to change. I mean, it will change, I promise you. It will change, because you have combination preventions that even in the absence of treatment are going to bring down infections. Then if you aggressively treat people, the chances of those people infecting somebody else is so low that you're right. I mean, I've been talking about that number for a really long time, that for every person you put on therapy, 1.5 to 2 people get infected. I think, and that's what Eric Goosby and Secretary Clinton called a tipping point, when in fact you have more people who are going on therapy than getting infected. And once you get past that tipping point, then you're going to start seeing go down like that. So you're right. You can't just say, oh, we'll just treat people and they'll be okay. It's going to synergize. It's going to be combination non-treatment prevention with the massive effect of treatment as prevention.
Okay.
I never say trust me, and don't ever believe a government worker who says trust me, but trust me on that one.
Okay.
All right.
Thank you.
Thank you for a wonderful presentation. My question is, with the assumption or expectation that the countries themselves, the third world countries, will take responsibility of their own, if this is the right stage or time to expect them to take responsibility, and if so, how is it going to slow or harm the population there and the research, the progress of the research itself?
So when you say the other countries that I'm talking about, why they take responsibility,
Yes.
no, they are starting to do that right now. And I think, I mean, again, you can't force a country to do that, but there are enlightened leaders who are starting to take full responsibility. They've done studies where you look at the economic impact of an out-of-control epidemic. It has such deleterious effects on the country that now that they realize that, they have to make that an important part of what their investment is. Previously, when the United States gives money, they say, oh, that's great. Now we could spend it for something else, not the money you give us. Now we don't have to worry about that problem. When they realize they have to worry about their problem, then they'll appropriate, or whatever they do in those countries, the money to that particular problem. And that's why country ownership is absolutely the answer, because we can't do it forever.
Okay, thank you.
How has the development of the AIDS science helped us in combating other diseases?
Enormously so, from a number of standpoints. So we know more about the workings and the regulation of the immune system than we have ever imagined have known by this dreadful, unfortunate experiment of nature about what happens when you knock out certain parts. The first thing. The secondly, it has totally invigorated the whole field of targeted drug development in any viral disease or in any disease where you use structural biology to be able to identify a vulnerable target. Thirdly, it's given us incredible insight into the role of chronic inflammation, which when you have a virus replicating for years, the most deleterious thing, among others, is the deleterious effect of chronic immune activation, which leads to endothelial proliferation and cardiovascular disease, kidney disease, liver disease, and aging. So we're learning more about the aging process by the chronic immune activation that we're seeing in people who are HIV. So there are multiple disciplines that are gaining an extraordinary amount of information from HIV. Thank you.